Good morning. Welcome to Veterinary Anesthesia. This is chapter 31 in your book, and we're going to be going through this lecture together. But I also wanted to record this for you to have for backup so that you can take a look at it later. So, introduction to anesthesia. So we're not going to talk about the deep details. You'll get that later. But I want you to have some basic understanding of it before you head into clinics or just to understand if you have your own animal going under anesthesia. It is a unique discipline. We use it very often, got frequent use of it. It's complex. It is high risk. Anesthesia means controlled death. So that's a pretty high risk procedure. It also can be very fast paced as well. So what is it? It's the absence of sensation. We have various grades of anesthesia, from tranquilization to light or heavy sedation to local or general anesthesia, which is controlled death, to muscle relaxation. Analgesia, the word analgesia means the absence of pain. Neuroleptalgesia is when we combine two different types of medication to get a semi-conscious, non-reactive state. We're not going to talk necessarily about those drugs. I do have a separate lecture for you if you want some bonus material so you have a basic understanding of some of those medications that you'll see in the clinic. But just understand that neuroleptalgesia will have some pain relief and also something that disassociates the brain from the body. Each practice that you go into is going to have its own set of protocols for anesthesia, but they're going to include things like a pre-medication. The pre-medication drug, one example would be acepromazine plus analgesic. Getting pain relief on board before we do cause any type of pain is the best way to keep pain from occurring. So an analgesic, an example of that would be an opioid like morphine. From there, we use the pre-medication drugs because they help us to lower the doses of other medications that we have to use, and it helps to smooth the transition into anesthesia. An induction drug is something that makes it easier for us to place a tube down into the trachea to help them breathe or to maintain anesthesia. So an induction drug, an example of that would be a ketamine diazepam mixture or propofol, which is a really, really common induction drug. And that's a really short-acting anesthetic that we then use just to get us to the point where we can maintain them on a drug. Usually using a gas anesthetic is a lot safer because we can, once we take them off the gas anesthesia, they wake up pretty easily. So first, before we put a pet under anesthesia, we need to get some historical information first. We need to make sure that they are going to be safe going under this controlled death. Important pre-anesthetic questions that you want to ask, because they're not going to volunteer it, is first of all, have we fasted the animal? Now in your book, chapter 31, there's a table. The first table has recommendations for size of pet, age of pets, breed of pet, species of pet, to tell you what the fasting recommendations are. The younger the pet or the quicker metabolism of the pet, the less time that we actually need to fast them. Now, why do we fast them? We fast them not only because we don't want them to vomit during anesthesia, but if we can fast them, we actually lower the gastric contents and the gastric juices, the acidity within the stomach. Even if you're not seeing them vomit and possibly aspirate the vomitus into their lungs, that's the most dangerous thing. But even when you're not seeing that, that gastric material can get into the esophagus if they've been eating lately and can cause some esophagitis. And that can be something dangerous that we can't see that will cause problems later. We also want to know, how are they feeling? What's their current condition? Have there been any changes in their condition since they scheduled that appointment? We get a lot of puppies that we schedule months in advance for a spay or neuter, and they bring them in for the spay or neuter, not remembering to mention Oh yeah, they haven't been eating well lately. They've had a little diarrhea. So we want to make sure that that everything is going okay. We want to make sure they're current on preventive care. We don't want to bring them into a hospital that may have sick patients when they're not protected. We want to make sure it's a scheduled procedure, and we want to know what kind of medications they're on because that may change what we do. Physical assessment, there are certain components that we pay particular attention to. Box 31-1 has some reportable conditions that you will want to report to your doctor. Basically looking at the level of consciousness, making sure that their vitals, their temperature, pulse, and respiration is good, and that we can hear their lung sounds without working too hard. We want to be able to make sure that they're not making too loud of respiratory sounds. Their respiratory system must be intact for most of the procedures that we do. We want to listen to their heart. We want to palpate their pulse. We want to make sure that we know what their body condition is. Are they weak? Do they have problems with their gait? Are they recumbent or not able to get up? Do they have any parasites, wounds, tumors, or lesions that we need to address first? Are there discharges from any part of their body? And what is their capillary refill time and their mucous membrane color? And this is a real quick physical assessment that you can do as you're taking a pet into the facility. Diagnostic testing that is excellent to do prior to doing anesthesia. The more information that you have about this animal, the better able you are to support it during anesthesia. So we want to do some blood work. We want to do some CBC or hematology, looking at the blood cells. We want to do a chemistry. We want to take a look at what's going on within the body. Doing an EKG, I've got a picture here of an app that you can have for your iPhone that can take an EKG. It's not the best EKG, but it's a quick EKG that just by placing it on the animal's chest. So we want to try to uncover abnormalities and make sure we know their signalment and their physical status class so that we can support them as best as we can during anesthesia. We have to make sure there are very few emergency surgeries that we should do right away. There are very few times that we want to put an animal under anesthesia before stabilization, and we'll talk about those. But if we have to put an animal under anesthesia because we have to maintain an airway, we might be able to do that as long as we can get that airway open as quickly as possible. If we have to stop bleeding, we may have to put them under anesthesia to stop the bleeding. If we have a bloat or a twisted stomach, what we call a gastrodilatation volvulus or GDV, we may want to put them under anesthesia quickly for that. But we still want to try to stabilize them as much as possible. So some things that we want to do would be run fluids for dehydration, a blood transfusion if they're anemic. Cardiac arrhythmias, we want to figure out what's causing that. We may need to treat that first. If there's any respiratory compromise, we have to be able to support that the lungs and make sure that they are oxygenating their brain and their tissues in order not to lose them during surgery. Any major organ failure, we want to try to fix that before we put them under the stress of anesthesia. And electrolyte or acid-base imbalances within their bloodstream and their body, we need to fix that as well. We have classifications that we're given by the American Society of Anesthesiologists that gives us a subjective, not objective, but a subjective rating of condition. And that's something that you can classify these animals in that helps you to develop your protocol to make sure you're doing the best thing for these animals. Any surgery that is an emergency, regardless of their ASA class, is also assigned the letter E. So if you have a true emergency surgery, whether it's an ASA class 1 or P1 to P5, if it's emergency, gets an E after that. So I believe actually the table is in 31-2, not 29-2. So table 31-2, it will give you one of those 5 classes. P1 being minimal, we got a nice healthy young pet, shouldn't have any problems going under anesthesia. To P5, will need severe support during like ICU type support during anesthesia. That helps the anesthetist to guide to manage that patient. So real quickly, I'm going to talk about inhalant anesthetics. I have another lecture for you to just go through some injectable anesthetics that we do prior to doing inhalant anesthetics. All medication is potentially dangerous to the body, some worse than others. Whatever we can do to minimize the amount of medication that we give to animals, that's what we want to do. And mixing medication in the right way can help us to lower the total amount of medication that we give to the animal. Inhalant anesthetics are liquid. They start as liquids. They're liquid agents, and they are vaporized with oxygen using these canisters. These canisters are under pressure, and under a certain pressure, they will vaporize that liquid into gas. So vapor pressure is the measurement of the tendency of the liquid to evaporate. Agents with a high vapor pressure evaporate readily and can reach dangerously high concentrations if they're not regulated. So we have these specific vaporizers that are color-coded based on what type of liquid you're putting in there. If you look at these three canisters, you see orange, purple, and yellow. Orange is farthest away from us, yellow is closest to us. And it says on them only fill with, and the purple and the yellow are the ones that you're going to see most often. Purple is isoflurane. Yellow is sevoflurane. And they are different types of anesthetics. They're both gas inhalant anesthetics, but they're slightly different in the way that you use them and how animals are affected by them. The differences are in their blood-gas partition coefficient and in their minimum alveolar concentration. And that's how quickly does it get from the lungs into the blood and how much of that gas need to be in the alveola in the lungs in order to create anesthesia for that pet. We have, it looks pretty complicated, but it really isn't. The anesthetic equipment that we use is delivered into the animal through the endotracheal tube. The anesthesia equipment, if you take a look at it, we have the patient here. There are two types of anesthesia equipment. This is a rebreathing unit, and what it does is it allows the anesthetic gas to come in to the animal, and then we have the expiratory limb that comes out, and we have a bag that we can use to push air back into the patient, but for the most part it goes out into a scavenging unit that removes carbon dioxide and removes the excess gas and takes it out. So here we go. Endotracheal tubes. This is how we put the anesthesia directly into the patient. It goes into the trachea. Helps us to maintain an open airway, minimizes the risk of pulmonary aspiration of blood, stomach contents, etc. And the way that it does that is we can close the tube off by blowing up this bubble. So this helps us, if this tube is not big enough to completely close off and seal that trachea, we can blow up this balloon here and that will fully close it. Now it is important to choose an endotracheal tube that is almost as big as the trachea, and that way we don't have to blow the balloon up quite so much. If we blow it up too much, it will cause damage of the trachea at that site and could cause some significant problems there. So we want to make sure when we are choosing a different types of endotracheal tubes that we are choosing the size, the width is almost as big as the trachea. And the other thing that we need to choose is the length. The longer this is, the longer this tube sticks out of the body, the more dead space there is for that animal to breathe past. If you think about it, the animal typically has lungs and a trachea, right? And so they're breathing in through the trachea and out through the trachea, and that trachea is dead space. That's where there is no exchange of oxygen with the body tissues. And so we want to limit that dead space by limiting the length of that endotracheal tube as well as increasing the width of that endotracheal tube. So it is important when you're looking at endotracheal tubes to get it as wide as possible and short enough that it just sticks out of the mouth a little bit. We don't want to increase that dead space. All right. So we use this anesthetic equipment not only to give anesthesia, but we also want to make sure that we can use it for oxygen, for giving animals oxygen. And also, if we need to ventilate a patient, whether they're under anesthesia to expand their lungs or they need help breathing, we have that little rebreathing bag that we can use to ventilate that patient, to push air back into the lungs. And so that's something that we might use the anesthetic equipment for as well. So a lot of different types of tracheal tubes. You can see, and different clinics will have different preferences. The size matters, and sometimes the type matters as well. It all has a connector. This connector is up here. It's D here is this connector. It goes between the anesthesia machine and the tracheal tube. We have this cuff, which we blow up to keep contents out of the lungs. And to keep the air in the lungs, we have a pilot balloon. This pilot balloon gives us a basic idea of how much air we're putting into this balloon that we won't be able to see what's in the patient. And there is a valve here. It's a one-way valve. You need to stick a syringe filled with air into that and press the valve in order to make sure that you're releasing it so you can put air in or take air out of this balloon. What we're looking for is this internal diameter, and that's how much airflow can we get through that trachea. And like I said, we want to make that as big as we possibly can. You may or may not use a laryngoscope in order to visualize the larynx. Everybody kind of has their own preference. If you have a really big mouthed animal and you can't see all the way back, these can be helpful to pull down the tongue and there's a light on it so that you can see way back into the mouth. So there are a lot of different blades and everybody has a different preference. Some people would just prefer not to use it. Anesthetic masks help us to administer oxygen or anesthetic gases if we have a patient that we cannot intubate yet because they're not asleep enough. We want to choose the smallest size possible for the animal so we get a nice good seal so we're not breathing in that anesthetic gas. In an anesthetic chamber, we don't use this often unless we have small patients that are fractious or feral or vicious or intractable that we can't handle in order to put a mask on or to give injections. It's clear so that we can observe the patient. We have a tube going in and a tube coming out. It is a good idea to fill this box with as much towel as possible, so the less dead space, the quicker the anesthesia gets into them. Once the animal is under anesthesia, we're going to move the box around just gently to make sure that they're completely out. Turn the gas off, try to flush out as much as possible, and then remove the animal and put a mask on them until we're sure they're down enough to intubate them. The anesthetic machine has specific areas. You are going to need to know these areas now and in the future. So it is important that you pay attention. So come back to slide 14 frequently because you need to know these things. This helps us to deliver anesthetics and oxygen. Use it during general anesthesia or if we have emergencies for pets that need oxygen. We have in A here, this is our carrier gas supply. The only gas we use in veterinary medicine is oxygen, and oxygen is categorized as green. These are green containers. The carrier gas, one of these tanks will be used at a time. We open up the tube and we allow a certain amount of gas to carry the anesthetic gas to the patient. This is the carrier B is the carrier gas supply, or the anesthetic vaporizer. So A is the carrier gas supply, B is the anesthetic vaporizer. It's going to be purple or yellow, isoflurane or sevoflurane, and that's the drug that is going to take it to the patient. C is our breathing circuit. And this is what takes the anesthetic and the oxygen to the patient and takes the carbon dioxide and the waste anesthetic gas out. And then our blue tube is our scavenging unit. So very basically 4 different systems. We've got our carrier gas, we've got our anesthetic vaporizer, we have our breathing circuit, and we have our scavenging system. Preparation, we have to make sure our anesthetic machine is working every day for every surgery. If it doesn't work, we're going to have one of 2 things happen. The patient will die because they're under too much, or the patient won't go to sleep properly, and we will be exposed to waste anesthetic gas. So bad things happen when you don't prepare. Box 31.2 will tell you about preparation for the anesthetic machine. Basically, we want to make sure the machine is assembled correctly and that we check for leaks. What we're going to do is there's a valve on the machine called the pop-off valve, and that shuts down, it closes the system so that this bag fills up. Now the problem is we have to make sure that that pop-off valve is always open when we have a patient attached to it. If it is not open when we have a patient attached to it, then this bag will fill up, and once it's full, the lungs will fill up. Now the bag is made of rubber, the lungs are not. Which one is going to pop first? The lungs. The lungs will pop if you don't open up that pop-off valve. But we need to check the system by closing it down. So we will shut down the pop-off valve, close the system, typically just put our thumb over the tube, and run oxygen through the system. If everything stays full and the pressure valve stays at the same spot, then we know we don't have any leaks. And that needs to be done either every day prior to surgery time or between every PET. We also want to make sure our carrier gas is all set. The carrier gas supply, again, it is oxygen, and that's where our liquid inhalant anesthetic evaporates and carries to the vapor to the patients. It has a yoke, an outlet valve, and a valve stem that need to be attached to the canister in order to deliver the gas. These compressed gas cylinders are very dangerous, and they need to be chained and set upright so that they don't fall down. If we break off that yoke, it turns into a rocket, and it will go through brick walls. So we want to be real careful with it. So oxygen is green. Internationally, it's white. We have 2 sizes. E is a small tank that you will see attached directly to the anesthesia machine. H will be a large tank. It's almost as tall as some of the shorter people in our class, so it's a really big tank. Some hospitals have an oxygen generator within the building, like major hospitals have those, and so there's a constant supply of oxygen. Really, really important that you are making sure that you are not handling these cylinders. Whoever's delivering those cylinders needs to handle them. Once they are put into place, they need to remain chained up so that they don't fall down. We need to be very careful with them. When we put them on, we need to make sure that there is an O-ring to stop any leaks. There is a yoke. This is the yoke, and it needs to be aligned with the holes in order to fit. We tighten it very tight, and then we can, once this is tight, we can open up the cylinder, and we have a pressure a manometer that tells us how much gas is in that cylinder. Anesthetic vaporizers hold liquid inhalant anesthetic, and they add vaporized anesthetic to the carrier gas. They are precision, meaning they have to work properly in order to pressurize these inhalants. Those inhalants that we use in veterinary medicine and human medicine are isoflurane and sevoflurane. There are non-precision inhalants. We don't use those anymore, so ignore that. In the vaporizer, there will be an inlet port, an outlet port, and a fresh gas inlet. We don't typically see those. What you typically see is something here, which takes a small amount of liquid and that needs to be opened up, filled, and closed up pretty rapidly so you don't inhale a lot of that liquid, because it will vaporize a little bit in the air. So the breathing circuits circulate fresh gases to the patient and convey waste gases to scavenging system. We have a closed total rebreathing system, a semi-closed partial rebreathing system, and a non-rebreathing system available. The smaller the animal is, the more we need to reduce the dead space. And so we use smaller systems, the non-rebreathing system, for smaller animals. This is just a basic idea of what it's supposed to look like. Some other things we haven't talked about, that tank pressure gauge tells you how much pressure is in that tank and when we need to change that tank. There is a pressure reducing valve to make sure there's too much pressure doesn't go through. There's a flow meter, tells us how much oxygen we're allowing to flow through the vaporizer. And with a vaporizer, there's something on top that tells us what percentage of anesthetic we're allowing to get to the pet, and that helps us to change the concentration. Okay, so this is a rebreathing circuit. Like I said, we have 2 tubes going in and out. Non-rebreathing will be 1 tube going in and an outer tube. The delivery tube is inside. The outer tube takes things away. That's called the non-rebreathing system. So with a rebreathing system, it's unidirectional flow valves going in, one going out. These 2 valves are at A and C up here, and you will see them moving as the patient breathes in and breathes out. The reservoir bag, or the rebreathing bag, is here, E. It's a rubber, so it will disintegrate over time. We do have to check for leaks in the bag. There's the pop-off valve right here, B, is your pop-off valve. It's a pressure relief valve. We sometimes close it down in order to fill the bag, but often we will, when you're attached to the pet, it should be open. This F is the carbon dioxide absorbent canister. There are special, it's called Sodazorb. These are special granules that will hold on to and absorb carbon dioxide. It is vital that we do that. So we grab the carbon dioxide out of the pet. And this Sodazorb does need to be changed periodically. We have a pressure manometer that tells us how much pressure is. Once you have this attached to the patient, that is a closed system. We need to know how much pressure is going on, is occurring in that closed system, because if you get above 20, you're going to blow up lungs. That's bad. So under 20 is where you want your pressure manometer. Write that down, under 20. Don't go above 20. Smaller pets, 15, 10. These are corrugated breathing tubes. These do need to be cleaned between patients, especially when you're doing dentals or something messy in the mouth. So we want to make sure that you do clean these regularly. The scavenging system is also very important. It's typically a light blue. You can see it in the corners here, right here. It transfers that waste gas outside of the building. We need to check it periodically and make sure that it is flowing outside of the building. It's important for you. Here's the leak test. See, this is somebody with a big thumb. My thumb's not that big. Sometimes I have to use the ball of my hand in order to stop that tube up so we get a closed system. So we need to make sure that we do that leak test all the time. We want to make sure that these rubber parts, that these O-rings are all in good working order. So we want to take a look at the parts, make sure that we have extras in the hospital, do an at least annual inspection. Usually we have somebody who's certified to do that come in. Want to disassemble it, we need to clean it periodically. All right, let's go to the patient. So done talking about the machines, let's go to the patient. Endotracheal intubation, really important that you get the right size, not just the diameter, but also the length, okay? So generally speaking, if you have a pet that needs it's bigger, needs a larger diameter, and needs a longer length. That's not always the case. Sometimes we have to cut these down. Keep it in mind. Another thing to keep in mind is that if you have a short-faced breed, a brachycephalic dog like a bulldog, French bulldog, or a pug, they take smaller tubes than you might think. You're going to use a much smaller tube on a bulldog than you would on a golden retriever, or even a cocker spaniel. Right size tubes, so make sure you get the right size tubes. Make sure you have something to tie that tube to the animal's muzzle with or to the animal's head with. We don't want it slipping out of place during the surgery. So sometimes we use gauze. So I like to use IV tubing because we can reuse IV tubing. That plastic tubing that we use to deliver IV fluids to a pet, we can cut that down and use that. It's easy to clean, it's easy to reuse. A gauze sponge, we are going to use a gauze sponge to grab that slippery tongue and pull it out of the mouth. We're going to use a syringe to blow up the cuff with air. An examination light or a laryngoscope will help us to visualize and see the back of the throat. And then with cats, or small breeds, we often need a stylet. A stylet is a firm rod that goes into the tracheal tube that makes these smaller tracheal tubes a little bit sturdier so that we can put it into the back of the throat. Diameter, we want at least 3 different sizes so we can choose the right one. We want those ready to go. The length is going to be from the nose to the thoracic inlet. So from there, you can measure before they fall asleep, from their nose to the thoracic inlet, which is where the throat enters the chest. This prevents hypoventilation, hypoxia, and dead space, so make sure that it is correct. Preparing the tube, we want to check that tube for damage, make sure that when we blow up the cuff, that balloon, there's no breakage in that balloon. Balloons break. Check that we have a secure attachment of this to the tube. Checking that cuff, make sure it stays inflated. For small animals, see figure 3117 in your book. Please turn to your book and take a look at that picture. But it's pretty easy to see with a large animal. Now you will notice her fingers are just inside his mouth, but her fingers are not inside his mouth. They are in between the canine tooth and the premolars. We don't want to put our fingers in the mouth where they can get bit. This animal is asleep, but not that asleep. Also, when you take the tongue out of the mouth and grab it, please push the tube against the tongue to move the tongue outside of the mouth. Do not stick your fingers in, even an animal that appears to be sleeping, do not stick your fingers in their mouth. Please use the tube to move their tongue aside. When you open their mouth, this is what you will see. The tongue, the epiglottis, E, and the soft palate above. That's the upper palate. What you're going to do is you're going to pull down the epiglottis, and when you do, ta-da, in between these goalposts, which are the vocal folds, you'll see the glottis. That is the opening to the trachea. That's what you want to see, and that's where you want to put your tracheal tube. It's a little different for horses and cattle. I'm just going to mention this really quickly. We're not really going to go into horses and cattle in this intro class. We do this blindly with horses where we extend their head, use a speculum. This is a speculum that allows us, it's a hollow speculum. We can stick the tube through it and it keeps their mouth open. They don't bite the tube. And we just hold their tongue out and just put it in until we feel it bump up against something, and when they inspire, we stick it down real quickly and then rotate it and have to check it. So it's a little bit difficult because we have to do it blindly. With cattle, we do it by we put a speculum in. This is a big cattle speculum. Pull their tongue out and stick our whole hand in their mouth and put it directly, feel their trachea and put it directly into their trachea. To check proper placement, we can just revisualize. We can hear them breathing, but we should not hear any sounds. Remember, we're going past their vocal folds, so we're taking the air away from their vocal folds. They should not be able to make any sounds except breathing sounds. We're going to watch the bag. Make sure that bag, once it's connected, expands and contracts as they breathe. We're going to look at the unidirectional valves. They'll pop up and down. We should be able to not feel it when we palpate the throat. We should only feel the trachea. We shouldn't feel anything besides the trachea. If we have it beside the trachea, it'll be in the esophagus and we'll feel 2 tubes in the throat. That's not right. So any vocalization means you're in the wrong spot. We need to replace it. Another good thing to have is if you have a carbon dioxide monitor, you should see these normal waveforms. It's a monitor we hook up to the tracheal tube that measures carbon dioxide coming out of the PET. If it looks like this, then you have carbon dioxide coming out of the PET, which means the tube's in the right spot. Okay, so once we have the tube in the right spot, here's a couple more pictures of what it would look like. We are going to want to seal the trachea with a cuff and check for leaks. We want to be real careful not to overinflate. If we overinflate, we're going to decrease the capillary flow here, and that's going to cause necrosis of that area. It's going to cause a bad cough in the pet afterwards. They can get a little irritated no matter what you do, but you're going to create some more problems if you overinflate. We also want to check for leaks. Leaks would be if you smell anesthesia gas, that would be a leak. Okay, we don't want to do that. Laryngospasm, we need to talk about that, especially with cats, swine, and small ruminants. What happens is they have a really strong reflex to close their glottis. And so if you touch it, it will close. We have to use lidocaine or a local anesthetic to deaden this so that we can get in there. The problem is this laryngospasm can be so bad that even if you're not touching it, it will remain closed, and so they will get hypoxic and become cyanotic, so that they will not be able to get oxygen to their tissues, so they will turn blue. So we want to prevent that by putting lidocaine on this area. That will deaden that. They won't be able to feel you poking and trying to get into their glottis. Monitoring. Monitoring is the cornerstone of successful anesthesia. There can be really, really subtle warning signs if you're not looking for them. They can seem to crop up really, really quickly, but you have to be very quick because complications develop quickly. Maintain the balance. You want to monitor frequently, so we usually say at least every 5 minutes you should be taking TPR and temperature, pulse, and respirations, checking their reflexes. You're going to be checking lots of different things all at once. It can seem overwhelming, but when you get into the rhythm of it, it becomes normal. You're checking all of the different parameters, make sure everything's functioning normally. Don't leave it to the instrumentation. Instruments don't work. They slip off, the recorders slip off the animal. We need to make sure that everything's working okay. And you don't want to judge anesthetic depth by dose or setting because every animal is different. You can say, well, I just had him on 1%, which is a really low dose of anesthetic, and he died. Well, 1% can kill an animal that is compromised in some way. Stages and planes of anesthesia, we're going to cover this again and again, but you need to know this. This is really important because if you get to stage 4, you're too late. We really need you to know these different stages because if you don't know them, you're going to kill a pet. So you need to know your stages and planes of anesthesia. So there are 4 stages. Stage 1, period of voluntary movement. So this is when they're just barely sedated and you call them out of their kennel. You've already given them their injection. You call them out of their kennel. They can move to you. They may be a little bit wobbly. They may look like a drunk, but they kind of know what they're doing. Stage 2 is when they are just paddling. So you've gotten them to the point where you're inducing them and they are unable to control their movements. We want to move them through stage 2 really, really quickly. What we found is that if we can move them from stage 1 to stage 3 really quickly, they do the same thing when they come out of anesthesia. So it makes everything super smooth. Stage 3 is your period of surgical anesthesia. Now, in stage 3, there are different planes we'll talk about in a minute, but I want to make sure that you know that stage 3 is where we do our surgery. Stage 4, you're too late. It's anesthetic overdose. You can come back from that, but typically you've killed some brain cells if you get to stage 4. Here are this is a typical anesthetic monitoring sheet. If you work in a hospital and you are not using a monitoring sheet that is at least somewhat like this, you need to make a change. This needs to happen with every pet and get into their record every time. We want to be observant of the pet during the entire procedure. We want to medically record everything that they have gotten, what dose we're giving them, the medications, both injectable as well as gas anesthesia. We want to make sure that we're monitoring what their physical status is before anesthesia, during anesthesia, and in the post-op period. So there are a lot of notes on here. These symbols are really easy. If you look at this, this is somebody just taking and putting a dot at a number. So we're at 60 beats per minute here, and we're at 130 beats per minute here. That's all it is. This little seagull means this is the top end of their blood pressure, and down here we have the bottom end of their blood pressure. So their blood pressure, they're monitoring blood pressure through here. What's it look like? We have the mean, the average of the blood pressure. So someone's just marking basically in between, and this is something that your monitoring equipment is going to give you. And your respirations are here. So if you do nothing else but pulse, respirations, and pulse ox, which is a measurement of oxygen in the bloodstream, that's at least some monitoring that you can do. Okay. So we want to look at stage 1, between stage 1 and stage 3, and plane 1 and plane 3. And we monitor that by what their reflexes are. Do they have a palpebral reflex? What is their eye position? Where's their jaw tone? And what is their movement in response to stimulation? Factors that influence stage progression are the IV agents, their inhalants, and the pre-medications. And like I said, we want to get from stage 1 to stage 3 as quickly as possible. So it's all going to depend on your anesthetic protocol. So there are physical signs that answer 2 questions, and this is the principle of your monitoring. Is the patient safe or in danger, and is anesthetic depth inadequate, excessive, or appropriate? So is the patient safe? Look at the vital signs. Indicators of circulation are heart rate, rhythm, and pulses, mucous membrane and capillary refill time, blood pressure. Indicators of oxygenation, pulse oximetry, or pulse ox, blood gas analysis, which we don't typically do in small animal medicine in smaller hospitals, but we will do it in certain situations. And then indicators of ventilation. So we can oxygenate tissues, but without breathing really well, that can be our first sign that we're having issues. So capnography, which is measuring the carbon dioxide level, this is actually one of the best ways of measuring if you're getting into trouble, and you can react to it much quicker. And then your respiratory rate. So that is our ventilation. If to know if the anesthetic depth is appropriate for the procedure, we're looking at reflexes. So palpebral reflex. If you touch the eyelid, does it blink? That tells us the depth. Pedal reflexes is if we pinch the toes, is there presence of pain? Those are 2 reflexes that they should not have if they're at the proper depth. They should have a little palpebral, real slight, but really no pedal reflex. Also muscle tone and jaw tone. Eye position and pupil size. If they are looking straight ahead but not moving their eyes, that's usually a pretty good indication that they are just about at the right depth. Eyes roll up in the head, they're a little deep. We have to be careful with that. And then response to surgical, and they should have good, no jaw tone when they're under anesthesia, or maybe really mild jaw tone. We don't want them to lose everything. They should not respond to any surgical stimulation. So if I'm making a cut or if I'm pulling on organs, they should not move or increase respiratory rate, etc. at all. Or should just be a light reaction to that. Principles of monitoring. So some of the equipment that we're going to use, an esophageal stethoscope, really cheap equipment. Basically what we do is it's an amplifier that you attach to your stethoscope and you slide it down their esophagus and it gets right to their heart, and you can hear their heart really easily. So we can use that. We can use esophageal catheters with a sensor and a base unit so that you can hear it without putting your stethoscope to your ears. EKG, really important to set your EKG up. We put the electrodes on the patient's skin, and we can monitor what the heart is doing and how it's working. You can't always hear arrhythmias, but we can see arrhythmias. Ultrasonic Doppler monitor detects blood flow through small arteries. This is a great thing to have for the surgeon to listen to so they can hear the heart rate going, but it's not always effective, and it should not be the only thing we're using to monitor heart rate. An oscillometric blood pressure monitor. This is much more common than it used to be. Putting a blood pressure cuff on an animal and monitoring the blood pressure really tells us what's going on with them. And then pulse oximeter can be really helpful. It's not the only thing we should use, but it does help us understand a little bit about how the tissues are being oxygenated. What I love the most is the capnography, the CO2 monitor. We can use an apnea monitor that tells us if they've stopped breathing, but if they've stopped breathing, it's too late. We're already behind the 8 ball on that one. What I'd rather see is a capnographer, which is end-tidal carbon dioxide monitor. It measures CO2 in inspired or expired air, and it gives us this wave for it. So inspiration, expiration, inspiration, expiration. When it is the best early warning system, when we are not ventilating properly, it is the first sign that something's going wrong with anesthesia. So we want to see these normals all the way throughout anesthesia. Okay, so practically speaking, what does this look like in small animals anesthesia? So first of all, we need to select a protocol. We need to get our pre-medications and our anesthetics ready for the right dose and the right route and the right order for that patient. Now, it is important that we make those choices before we see the patient, but then reevaluate after we've seen the patient and have done a physical assessment and looked at their blood work, etc. So don't pull up the meds before the patient comes in. Okay. Signalment. Signalment will tell us a lot about the patient. Remember, breed, age, sex is going to tell us a lot about possible pre-existing problems, their physical status, class, and procedure. Typically, with brachycephalic dogs, we're a lot more careful with anesthesia. They just don't breathe well on their own in a normal situation. To be prepared to do anesthesia, we need to get our equipment gathered, checked, organized before the procedure. If you're a surgical nurse, you're going to get to work early. You're going to make sure you've done your leak test. You're going to make sure everything's in place, all your items are sterilized, and you're ready to go. When the animal comes in, we have our pre-anesthetic period. We want to do our physical assessment, get our history, get our lab results, make sure that patient is stable, place an IV catheter, especially if it's going to be a longer surgery procedure, and begin fluids. I like to begin fluids prior to surgery and keep them going during surgery. It helps to stabilize the pet. And then start to administer your pre-medications. IV induction, once they are sedated and calm and pain-free, we start the IV induction. We're going to administer it to effect and not beyond. Check the vitals real quickly, remove the restraints, and try to get them intubated as quickly as possible. IM induction, we can do IM for some medications. In some pets, it takes a little bit longer. It's usually 2 to 3 times the IV dosage, so we're giving more medication. That's not always great. And it's harder to control than IV induction. So we usually try IV induction first. Mask induction is we use a fast-acting inhalant anesthetic. It can be challenging because patients don't like this nasty-smelling gas forced on their face. You do have to have them restrained. Once they start breathing it within a couple of breaths, they're usually relaxed, but it can make things a little difficult, especially as they're waking up because we haven't pre-medicated them. Chamber induction is usually only for smaller aggressive patients because there is a higher risk. Anesthesia and patient positioning. Maintenance, we want to administer the anesthesia just to keep the patient in the desired plane of anesthesia. We want a frequent evaluation. Make sure we typically are using inhalant anesthetics. Some inhalant anesthetics, it takes a couple of minutes for them to get it out of the system. Sevoflurane takes 2 breaths. So there are different benefits to that. And then if we have IV maintenances, you may be responsible for giving as needed repeated what we call boluses. So repeated doses, larger doses of the IV medication to keep them under anesthesia. When we position a patient while they're under anesthesia, we want to make sure that we have them in the correct placement for the surgery. Make sure their temperature is maintained. When a pet goes under anesthesia, temperature drops, and that actually makes our anesthesia much more difficult, and it's harder to wake them up when they're colder. So we want to keep track of their temperature and want to maintain their temperature as much as possible. Want to make sure their eyes are lubricated because they don't close their eyes during anesthesia. We make sure that we can protect that cornea, and make sure that their blood pressure, there's no pressure on their body in places that is going to cause damage later on. Anesthetic recovery. So there are a lot of factors to anesthetic recovery. As we're waking pets up, we need to be able to transfer them, extubate them, and monitor them as they're waking up. Once we have the anesthetic off, that doesn't mean that the patient is fine. We have to make sure that they're okay. Once we stop the inhalant anesthetic, we're going to want to continue oxygen for a couple of minutes to really flush out their system. We're going to start to remove unnecessary equipment, and we want to continuously keep the patient warm and turn the patient. If the patient has been on one side or the other, we want to turn them to allow their lungs to inflate on the other side. That'll help them to wake up a little bit quicker. Once we have them unhooked from gas, we do want to keep them at arm's length. We don't want to breathe in that waste anesthetic gas. Put them in a cage or in a place where they're on the ground so they're not going to hurt themselves. Watch their mucous membranes, watch their respirations. We do not extubate patients until they're ready because we want to make sure that we have access into their lungs if we have any emergencies. They are going to progress back through the stages and planes of anesthesia the same way they went down. So if they had a rough induction, they're going to have a rough recovery. So be prepared for that. We want to prepare to prevent them from any self-trauma. Sometimes they wake up flopping around and hit their head. We want to try to keep them from doing that. Extubation, we're going to remove that tube when the swallowing reflex returns. I like to see them swallow at least 2 times. And to be honest, with brachycephalic dogs, I almost want them sitting up on their sternum and maybe even chewing on the tube a little bit before I take that out. So I'm going to be really sitting there with them and watching them very closely. If we're doing dentals or anything in the mouth that produces a lot of fluid, we want to make sure that that fluid is drained and they're swallowing really well before we deflate the cuff even and remove that tube. Post-anesthetic period, make sure that you have your patient discharge instructions ready to go. Restricting food for several hours afterwards and then reintroducing food and water very gradually to make sure they're not vomiting and they're able to swallow is a good idea. Let's talk a little bit about ventilation. Ventilation is when we have to breathe for an animal. Ventilation forces air or anesthetic gases into the lungs, and it compensates for respiratory depression. So if we anesthetize them enough that they are not able to breathe, then we can compensate by breathing for them. And we can also keep patients alive if their breathing fails for whatever reason. Manual ventilation is in lieu of a mechanical ventilator. A mechanical ventilator is one of those machines that has a bellows in it that goes up and down mechanically or automatically. For mechanical ventilation, you're going to have to set the pressure cycle and the time cycle, so how much pressure and time you're going to give it. For manual, you're squeezing the bag to a certain pressure. You're looking on your manometer to make sure you're doing to no more than 20, right? And that you're doing the rate at the rate that the animal needs. Periodic ventilation is important for any normal, healthy patients. In small animals, we want to breathe for them. Even if they're breathing normally on their own under anesthesia, we want to give them a nice big breath, up to 20, every 2 to 5 minutes, just to inflate their lungs all the way, get the blood flow moving, and get the air moving through them. If they're apneic or not breathing, or hypoventilation, not breathing as much, we want to give them a breath every 15 seconds or 4 times a minute. We're going to do that for about 5 minutes. It just depends on their specific need. We do have to do mandatory ventilation in large animal patients. They cannot move their chest wall as well when they're under anesthesia. If we have an exposed thoracic cavity, that means we've opened up the chest, then we've lost our pressure in the chest and we have to breathe for them because the lungs cannot inflate on their own. And if we have neuromuscular blockers, those are medicines that keep the lungs from inflating or keep the muscles from inflating the lungs, then we need to also ventilate for the patient. So complications of ventilation, we can cause problems if we put too much pressure. If we use positive pressure ventilation, we can reduce the venous return and drop the blood pressure, so we have to be careful of that. If there's excess pressure, we can cause a pneumothorax or a pneumomediastinum, meaning we're pushing air actually out of the lungs, exploding the lungs and into the chest cavity, which will reduce cardiac output as well. If we have excessive respiratory minute volume, we can cause respiratory alkalosis, and that's just if we have decreased the amount of carbon dioxide available that changes the acid-base status of the blood. If we have inadequate, we're going to cause respiratory acidosis. So if we're not ventilating enough, we're going to do the opposite. We're going to leave carbon dioxide in the body, and that's going to cause a respiratory acidosis. So you have to do it not too much, not too little, at the right pressure, no pressure on you. Anesthetic problems and emergencies. So if we have a problem or emergency, there are usually possible influences or causes. If they have a pre-existing condition, if they're really, really old or really, really young, obese or pregnant, we have to be careful with that. Adverse drug reactions, we can't always predict, but sometimes there are dogs that just have an adverse drug reaction. Equipment malfunction, you can control those, so please watch that. Anesthetic overdose, you also control that. Please watch that. Complications of surgery and human error. Common problems that we see in emergencies during anesthetic, if we have an empty or turned off oxygen tank, so always check your oxygen tank. Endotracheal tube is not in the right spot. It's disconnected or it's blocked in some way. If your pop-off valve is too far closed, remember I said always should be open when you're dealing with a pet attached to it. If you have a maladjusted leaking scavenging system, that can cause problems. If you have high or inadequate oxygen flow, that'll be a problem. Overzealous use of the oxygen flush valve is a major problem. People like to push that flush valve thinking that they're doing a good job in flushing oxygen into the patient or filling the bag. That doesn't work the way you think it does. If you have too much saturation of your CO2 absorbent, that Sotasorb, if you're not changing it frequently enough, your patient will not stay asleep or they will go to sleep forever. So we want to watch those things. There are lots of things that you control. One thing I do want to say real quick about that endotracheal tube, making sure that you're taking care of it. Whenever we turn a patient on the table, we always have to disconnect the anesthesia machine from the endotracheal tube. It is vital that you do that. If you turn the patient while still attached to the anesthetic machine, you can lacerate the trachea. So always disconnect. So make sure that you are controlling all of these things and making sure that you're staying on top of it. It seems like a lot, but over time it will become really easy to you. So some problems to troubleshooting. So if they're not staying asleep, there's an equipment problem. You either have a leak, your Sotasorb has not been changed, there's something going on with the equipment. If they're too deep, it's because, first of all, check your vaporizer settings. Make sure that you are decreasing that. It could be equipment problems, or it could be a pre-existing condition. If you have cardiopulmonary arrest, they stop breathing and their heart stops beating, it's because you did not correct that anesthetic depth. You need to watch that. Apnea or hypoventilation usually follows hyperventilation or induction with respiratory depressants, and most of the induction agents that we use, if given too quickly, will depress the respiratory system. So you want to be careful not to hyperventilate because then they'll stop breathing, and you want to be careful not to give the induction agent too quickly because they will stop breathing then. Hypotension, there are several causes for that, so low blood pressure. A lot of them can be due to medications or not having appropriate fluid therapy. Hypoxemia, you'll see cyanosis or not breathing very well. Vomiting regurgitation causes pulmonary aspiration. Prolonged recovery, there are several causes. Most common cause would be hypothermia or a pre-existing disease, or if we're using medications like barbiturates or dissociatives that just last longer in the body. A rough recovery is common if the animal is not pre-medicated. We call it a rough recovery when they're vocalizing, thrashing around, otherwise could cause self-harm. So if you have any questions, let's chat. Shoot me an email, shoot me a chat. Let's talk about it and discuss.